Hi guys, good day to all of you. I am Charmaine G. Fantunalgo, a third year AB Psychology A student from College of Arts and Social Sciences, University of Southern Mindanao, Cabacan, and I will be your reporter for today. I am with Baby Lindsay Altizo and Eliza May Macagba, and our topic would be about paraphilic disorders and other mental disorders. So throughout the video, I will be giving you the definition of the disorders, a little background, changes to diagnosis from DSM-4 to DSM-5, when can it be diagnosed, its etiology, and DSM symptomatology. For our topic outline, we have paraphilic disorders, and under it we will discuss the voyeuristic disorder, exhibitionistic disorder, fraudoristic disorder, sexual masochism disorder, sexual sadism disorder, pedophilic disorder, fetishistic disorder, and transvestic disorder. And for other mental disorders are other specified mental disorder due to another medical condition, unspecified mental disorder due to another medical condition, other specified mental disorder, and unspecified mental disorder. At first, let us discuss paraphilic disorders. Paraphilic disorders that are included in this manual are the following. Again, is the voyeuristic disorder, which is spying on others in private activities. Exhibitionistic disorder, which is about exposing the genitals. Fraudoristic disorder, or the touching or rubbing against a non-consenting individual. Sexual masochism disorder, which is undergoing humiliation, bondage, or suffering. Sexual sadism disorder, which is inflicting humiliation, bondage, or suffering. Pedophilic disorder, which is the sexual focus is on children. Fetishistic disorder, which is using non-living objects or having a highly specific focus on non-genital body parts. And transvestic disorder, which is engaging sexually across cross-dressing. So these disorders have traditionally been selected for specific listing and assignment of explicit diagnostic criteria in DSM for two main reasons. So first reason is that they are relatively common in relation to other paraphilic disorders. The second reason is that some of them entail actions for their satisfaction that, because of their noxiousness or potential harm to others, are classified as criminal offense. So in this chapter, the order of presentation of the listed paraphilic disorders generally corresponds to common classification schemes for this condition. The first group of disorders is based on anomalous activity preferences, and these disorders are subdivided into courtship disorders, which resemble distorted component of human courtship behavior, which are the voyeuristic disorder, exhibitionistic disorder, and fraudoristic disorder. And algolagnic disorders, which involves pain and suffering, and under it is the sexual masochism disorder and sexual sadism disorder. The second group of disorders is based on anomalous target preferences, and these disorders include one directed at other humans, which is the pedophilic disorder, and two directed elsewhere, which are the fetishistic disorder and transvestic disorder. And now let us define paraphilia. This term denotes any intense and persistent sexual interest other than sexual interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. So in some circumstances, the criteria intense and persistent may be difficult to apply, such as in the assessment of persons who are very old or medically ill and who may not have intense sexual interest of any kind. In such circumstances, the term paraphilia may be defined as any sexual interest greater than or equal to normophilic sexual interest. There are also specific paraphilias that are generally better described as preferential sexual interest than as intense sexual interest. So some paraphilias primarily concern the individual's erotic activities, and other primarily concern the individual's erotic targets. So examples of individuals' erotic activities include intense and persistent interest in spanking, whipping, cutting, binding, strangulating another person, and interest in these activities that equals or exceeds the individual's interest in copulation or equivalent interaction with another person. The examples of individuals' erotic targets would include intense or preferential sexual interest in human, non-human animals, and inanimate objects are children, corpses, amputees, horses, dogs, shoes, and articles made of rubber. Paraphilic disorder is a paraphilia that is currently causing distress or impairment to the individual, or a paraphilia whose satisfaction has entailed personal harm, risk of harm to others. And a paraphilia is a necessary but not sufficient condition for having a paraphilic disorder. And a paraphilia by itself does not necessarily justify or require clinical intervention. And the diagnostic criteria set for each of the listed paraphilic disorders. Criterion A specifies that qualitative nature of paraphilia, for example, an erotic focus on children or on exposing the genitals to strangers. And criterion B specifies the negative consequences of the paraphilia, which is distress, impairment, or harm to others. In keeping with the distinction between paraphilias and paraphilic disorders, the term diagnosis should be reserved for individuals who meet both criteria A and B. So that is individuals who have a paraphilic disorder. If an individual meets criterion A but not criterion B for a particular paraphilia, a circumstance that might arise when a benign paraphilia is discovered during the clinical investigation of some other condition, then the individual may be said to have that paraphilia but not a paraphilic disorder. Now let us move on to voyeuristic disorder. So voyeuristic disorder is a condition that causes a person to act on voyeuristic urges or become so consumed by voyeuristic fantasies that they are unable to function. It refers to a persistent, intense, atypical sexual arousal pattern independent of whether it causes any distress or impairment, which by itself would not be considered disordered. So the changes to diagnosis from DSM-4 to DSM-5 in voyeuristic disorder is that in DSM-4 TR, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving the act of observing an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity is termed as voyeurism. In DSM-5, over a period of at least 6 months, recurrent or and intense sexual arousal from observing or an unsuspecting person who is naked in the process of disrobing or engaging in sexual activity is termed as voyeuristic disorder. So when it can be diagnosed? The diagnostic criteria for voyeuristic disorder can apply both to individuals who are more or less freely disclosed to paraphilic interest and to those who categorically deny any sexual arousal from observing an unsuspecting person who is naked, disrobing, or engaged in sexual activity despite substantial objective evidence to the contrary. If disclosing individuals also report distress or psychological problems because of the voyeuristic sexual preferences, they could be diagnosed with voyeuristic disorder. On the other hand, if they declare no distress demonstrated by lack of anxiety, obsessions, guilt, or shame about these paraphilic impulses and are not impaired in other important areas of functioning because of this sexual interest, and their psychiatric or legal histories indicate that they do not act on it, they could be ascertained as having voyeuristic sexual interest but should not be diagnosed with voyeuristic disorder. The etiology of voyeuristic disorder is that there is no particular cause that has been identified for voyeuristic disorder, but certain risk factor could increase a person's likelihood to develop this condition. Factors such as sexual abuse, substance abuse, hypersexuality, and sexual preoccupation. For the symptomatology, according to DSM-5, the most common symptoms of voyeuristic disorder are experiencing intense sexual fantasies and urges or getting sexual gratification from watching a person naked with or without consent of the target. So not everyone who has voyeuristic tendencies suffers from voyeuristic disorders. Let us proceed with exhibitionistic disorder. So, exhibitionistic disorder involves acting on exhibitionistic urges or fantasies or being distressed by or unable to function because of those urges and fantasies. The changes to diagnosis from DSM-4 to DSM-5 of exhibitionistic disorder is that in DSM-4, over a period of at least 6 months, recurrent intense sexually around fantasies, sexual urges, or behaviors involving the exposure of one's genitals to an unsuspecting person is termed as exhibitionism. And in DSM-5, over a period of at least 6 months, recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting person is termed as exhibitionistic disorder. So when it can be diagnosed? The diagnostic criteria for exhibitionistic disorder can apply both to individuals who more or less freely disclose this paraphilia and to those who categorically deny any sexual attraction to exposing their genitals to unsuspecting persons despite substantial objective evidence to the contrary. If disclosing individuals also report psychosocial difficulties because of their sexual attractions or preferences for exposing, they may be diagnosed with exhibitionistic disorder. In contrast, if they declare no distress, exemplified by absence of anxiety, obsessions, and guilt or shame about these paraphilic impulses, and are not impaired by these sexual interests in other important areas of functioning, and their self-reported psychiatric or legal histories indicate that they do not act on them, they could be ascertained as having exhibitionistic sexual interest but not diagnosed with exhibitionistic disorder. The etiology of exhibitionistic disorder typically develops during adolescence, early adulthood. Antisocial history, alcohol or other substance misuse, and pedophilic sexual preferences may increase the risk of developing exhibitionistic disorder, although causality has not been determined. Antisocial history, alcohol or other substance misuse, and pedophilic sexual preference might also increase the risk of sexual recidivism in exhibitionistic offenders. The symptomatology of exhibitionistic disorder is that the DSM-5 states that the behaviors associated with this disorder will have occurred over a period of 6 months, are recurrent, and result in intense sexual arousal from the exposure of one's genitals to a stranger or unsuspecting individual. It is an uncontrollable sexual urge that is deliberately intended for an unconsenting person. Exhibitionistic disorder results in significant clinical distress and impairs social, occupational, and or other normal life functions. It is important for the diagnostician to determine whether the exposure behavior is specific to children or adults, and the environment in which it is most likely to occur. Now we have frauduristic disorder. Frauduristic disorder is a rare and poorly researched type of paraphilia. It involves the act of touching or rubbing one's genitals against another non-consenting individual in a sexual manner to attain sexual gratification. This activity reviews the evaluation and treatment of this disorder and highlights the interprofessional team's role in evaluating and treating patients with this condition. The changes to diagnosis from DSM-4 to DSM-5 is that in DSM-4, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving touching or rubbing against a non-consenting person is termed as fraudurism. In DSM-5, over a period of at least 6 months, recurrent and intense from touching or rubbing against a non-consenting person is termed as frauduristic disorder. So when can it be diagnosed? The diagnostic criteria for frauduristic disorder can apply both to individuals who relatively freely disclose this paraphilia and to those who firmly deny any sexual attraction from touching or rubbing against a non-consenting individual regardless of considerable objective evidence to the contrary. If disclosing individuals also report psychosocial impairment due to their sexual preferences for touching or rubbing against a non-consenting individual, they could be diagnosed with frauduristic disorder. In contrast, if they declare no distress demonstrated by lack of anxiety, obsessions, guilt, or shame about these paraphilic impulses and are not impaired in other important areas of functioning because of this sexual interest, and their psychiatric or legal histories indicate that they do not act on it, they could be ascertained as having frauduristic sexual interest but should not be diagnosed with frauduristic disorder. Its etiology is that it is not known, but many theories exist regarding the cause of fraudurism. Psychoanalysts propose that individuals with fraudurism may have unmet needs to rub themselves against the victim and cuddle, like an infant with his mother. Individuals engaging in these behaviors may fantasize that they share an exclusive and caring relationship with their non-consenting victims during the act. Freud and said to have proposed that these individuals may also have problems with tactile interactions that may occur during normal human erotic or sexual intercourse. These have been some research to postulate a biological mechanism, primarily with the monoamine pathway, resulting in abnormal sexual behaviors. The symptomatology of frauduristic disorder is that the behavior exists for a minimum of half a year. He feels a great amount of anxiety from his actions, and there is impairment in person's everyday life. Next, we have the sexual masochism disorder. Sexual masochism is intentional participation in an activity that involves being humiliated, beaten, bound, or otherwise abused to experience sexual excitement. Sexual masochism disorder is sexual masochism that causes significant distress or significantly impairs functioning. Changes to diagnosis from DSM-4 to DSM-5 for sexual masochism disorder is that in DSM-4, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving the act, real not simulated, of being humiliated, beaten, bound, or otherwise made to suffer is termed as sexual masochism. In DSM-5, over a period of at least 6 months, recurrent and intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer is termed as sexual masochistic disorder. So when it can be diagnosed? The diagnostic criteria for sexual masochism disorder are intended to apply to individuals who freely admit to having such paraphilic interests. Such individuals openly acknowledge intense sexual arousal from the act of being humiliated, beaten, bound, or otherwise made to suffer, as manifested by fantasies, urges, or behaviors. If these individuals also report psychosocial difficulties because of their sexual attractions or preferences for being humiliated, beaten, bound, or otherwise made to suffer, they may be diagnosed with sexual masochism disorder. In contrast, if they declare no distress, exemplified by anxiety, obsessions, guilt, or shame about these paraphilic impulses, and are not hampered by them in pursuing other personal goals, they could be ascertained as having masochistic sexual interest but should not be diagnosed with sexual masochism disorder. The etiology of sexual masochism disorder is that there is no universally accepted theory explaining the roots of sexual masochism. However, several ideas have been advanced. One theory suggests that paraphilias originate when inappropriate sexual fantasies are forbidden and become stronger as they are suppressed. Another theory suggests that sadomasochistic behavior is a form of escape from one's thoughts and allows the practitioner to enter into something resembling a meditative state. Through acting out fantasies, individuals allow themselves to feel new and different. Another theory suggests that childhood trauma such as sexual abuse can later manifest in a paraphilic disorder. The symptomatology of sexual masochism disorder is that, according to DSM-5, to be diagnosed with this disorder, a person must experience recurrent and intense sexual arousal from being beaten, humiliated, bound, or aroused from some other form of suffering. This type of urges, fantasies, or behaviors must be present for at least 6 months and cause clinically significant troubles or difficulty in social, occupational, and other important areas in life. So after we discuss the sexual masochism disorder, let us now move on with sexual sadism disorder. Sexual sadism disorder is a condition associated with sexual arousal resulting from the suffering of another person. Sexual sadism disorder is sexual sadism that causes significant distress or significant functional impairment or is acted on with a non-consenting person. Changes to diagnosis from DSM-4 to DSM-5 for sexual sadism disorder is that in DSM-4, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving acts, real and not simulated, in which the psychological or physical suffering, including humiliation of the victim, is sexually exciting to the person, and it is termed as sexual sadism. And DSM-5, over a period of at least 6 months, recurrent and intense, from the physical or psychological suffering of another person is termed as sexual sadism disorder. So when it can be diagnosed? The diagnostic criteria for sexual sadism disorder are intended to apply both to individuals who freely admit to having such paraphilic interest and to those who deny any sexual interest in the physical or psychological suffering of another individual despite substantial objective evidence to the contrary. Individuals who openly acknowledge intense sexual interest in the physical or psychological suffering of others are referred to as admitting individuals. If these individuals also report psychosocial difficulties because of their sexual attractions or preferences for the psychological and physical suffering of another individual, they may be diagnosed with sexual sadism disorder. In contrast, if admitting individuals declare no distress, exemplified by anxiety, obsessions, guilt, or shame about these paraphilic impulses and are not hampered by them in pursuing other goals, and their self-reported psychiatric and legal histories indicate that they do not act on them, then they could be ascertained as having sadistic sexual interest, but they would not meet criteria for sexual sadism disorder. Its etiology is that no specific causes have been determined for sexual sadism disorder. There are several theories. These include escapism, or a feeling of power for someone who normally feels powerless in day to day life, release of suppressed sexual fantasies, or progressive acting out of sadistic sexual fantasies over time. The symptomatology for sexual sadism disorder is that it is a whole marked by intense feelings of sexual excitement when fantasizing about or witnessing another individual undergoing physical or psychological pain. Acts of sexual sadism may occur with a consenting partner or as assault on a non consenting individual, according to the American Psychiatric Association, year 2013. Now, let us move on with pedophilic disorder. Pedophilic disorder pertains to both individuals who freely disclose these paraphilic interests and individuals who deny any sexual attraction to prepubescent children or those children years and younger, despite substantial evidence of the attraction. The changes to diagnosis from DSM-4 to DSM-5 for pedophilic disorder is that the notable detail is what wasn't revised in the new manual. Although proposals were discussed through the SM5 development process, the diagnostic criteria ultimately remained the same. In DSM-4 TR, only the disorder name will be changed from pedophilia to pedophilic disorder to maintain consistency with the chapter's other listings. So when it can be diagnosed? The diagnostic criteria for pedophilic disorder are intended to apply both to individuals who freely disclose this paraphilia and to individuals who deny any sexual attraction to prepubertal children or generally aged 13 years or younger, despite substantial objective evidence to the contrary. Examples of disclosing this paraphilia include candidly acknowledging an intense sexual interest in children and indicating that sexual interest in children is greater than or equal to sexual interest in physically mature individuals. If individuals also complain that their sexual attractions or preferences for children are causing psychosocial difficulties, then they may be diagnosed with pedophilic disorder. However, if they report an absence of feelings of guilt, shame, or anxiety about these impulses and are not functionally limited by their paraphilic impulses, and their self-reported and legally recorded histories indicate that they have never acted on their impulses, then these individuals have a pedophilic interest but not pedophilic disorder. Its etiology is that different theories exist about what causes pedophilia. Some experts propose that the causes are neurodevelopmental. Differences in the brain structure of pedophiles have been noted, such as frontocortical differences, decreased gray matter, unilateral and bilateral frontal lobe and temporal lobe, and cerebellar changes. According to research, these differences are similar to those of people with impulse control disorders such as OCD, addictions, and antisocial personality disorder. Pedophilia could be a byproduct of other comorbid psychiatric diseases. These brain abnormalities may have been formed by abnormal brain development. However, post-traumatic stress disorder also causes these types of brain abnormalities. Traumatic experiences in the pedophile's early life could have caused this atypical development by Hall and Hall in 2017. The symptomatology of pedophilic disorder is that according to DSM-5, there are three criterion with six specifiers. An individual who has had arousing fantasies about urges for or behaviors with a prepubescent child or children. An individual has acted out the sexual desires or is experiencing significant distress or difficulty as a result of these desires, and the individual is 16 years of age and at least 5 years older than the child or children noted in Criterion A. The specifiers are exclusive type sexual attraction to children only, non-exclusive type sexual attraction to adults and children, attraction to boys, attraction to girls, and incestuous only. Now, we will discuss the fetishistic disorder. Fetishistic disorder refers to recurrent intense sexual arousal from use of an inanimate object or from a very specific focus on a non-genital body part or parts that causes significant distress or functional impairment. The changes to diagnosis from DSM-4 to DSM-5 is that in DSM-4, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving the use of non-living objects, for example, is that the female undergarments is called fetishism. In DSM-5, over a period of at least 6 months, recurrent and intense sexual arousal from the use of non-living objects or a highly specific focus on non-genital body parts is termed as fetishistic disorder. So when it can be diagnosed? A diagnosis of fetishistic disorder must include clinically significant personal distress or psychosocial role important, which is the Criterion B. Common fetish objects include female undergarments, male or female footwear, rubber articles, leather clothing, or other wearing apparel. Highly eroticized body parts associated with fetishistic disorder include feet, toes, and hair. It is not uncommon for sexualized fetishes to include both inanimate object and body parts. Example is the dirty socks and feet. And for this reason, the definition of fetishistic disorder now reincorporates partialism. So there is only an exclusive focus on a body part into its boundaries. So partialism, previously considered a paraphilia not otherwise specified disorder, had historically been subsumed in fetishism prior to DSM-3. Its etiology is that paraphilia such as fetishistic disorder typically have an onset during puberty, but fetishes can develop prior to adolescence. No cause for fetishistic disorder has been conclusively established. Some theories believe that fetishism develops from early childhood experiences in which an object was associated with a particular powerful form of sexual arousal or gratification. Other learning theories focus on later childhood and adolescence and the conditioning associated with masturbation and puberty. Behavioral learning models suggest that a child who is the victim or observer of inappropriate sexual behaviors may learn to imitate or later be reinforced for the behavior. Compensation models suggest that these individuals may be deprived of normal social sexual contacts and thus seek gratification through less socially acceptable means. The symptomatology for fetishistic disorder include over a period of at least 6 months, a person has had recurrent and intense sexual arousal from fantasies, sexual urges, or behaviors from either the use of non-living objects or a highly specific focus on non-genital parts. The fantasies, sexual urges, and behaviors are causing clinically significant distress or impairment in social, occupational, or other important areas of functioning. The fetish objects are not limited to articles of clothing used in cross-dressing, as is transvestic disorder, or devices specifically designed for the purpose of genital stimulation, such as vibrator. And now we are down with the last disorder under paraphilic disorder, which is the transvestic disorder. So transvest TSM involves recurrent and intense sexual arousal from cross-dressing, which may manifest as fantasies, urges, or behaviors. Transvestic disorder is transvestism that causes significant distress or significant functional impairment. The changes to diagnosis from DSM-4 to DSM-5 is that on DSM-4, over a period of at least 6 months, recurrent intense sexually arousing fantasies, sexual urges, or behaviors involving cross-dressing in a heterosexual male is termed as transvestic fetishization. In DSM-5, over a period of at least 6 months, recurrent and intense sexual arousal from cross-dressing is now termed as transvestic disorder. So when it can be diagnosed? The diagnosis of transvestic disorder does not apply to all individuals who dress as the opposite sex, even those who do so habitually. It applies to individuals whose cross-dressing or thoughts of cross-dressing are always or often accompanied by sexual excitement, which is the criterion A, and who are emotionally distressed by this pattern or feel it impairs social or interpersonal functioning, which is the criterion B. The cross-dressing may involve only one or two articles of clothing. So for example, for men, it may pertain only to women's undergarments, or it may involve dressing completely in the inner and outer garments of the other sex, and in men may include the use of women's wig and makeup. Its etiology is that it isn't known exactly what determines transvestic disorder. The disorder has been found in youngsters when they dress up before reaching adolescence. The activity may remain the same with no change or increase, and the desire for sex usually spikes in puberty. The symptomatology for transvestic disorder is characterized by at least 6 months of experiencing recurring sexual arousal brought on by the act of cross-dressing. This arousal may manifest as sexual fantasies, behaviors, or urges that cause the patient significant distress or impairment in important areas of function, such as social or occupational settings. In transvestic disorder, feelings of distress at cross-dressing are separate from feelings of gender dysphoria, and individuals identify as their anatomical gender. Cross-dressing sessions may include as few as one item of clothing, such as an undergarment, or maybe as extensive as full clothing, makeup, and wigs, or hairstyling. This is often accompanied by patterns of purchasing, wearing, and then throwing out cross-dressing clothing in attempt to quit. Cross-dressing sessions typically leads to masturbation sessions in younger individuals, while older individuals typically delay gratification in order to extend the cross-dressing sessions. Individuals who are in sexual relationship may engage in intercourse with their partner either during or after cross-dressing sessions. It is important to note that transvestic disorder is distinct from fetishistic disorder where the target of the fetish is women's undergarments or clothing. So now we are in other mental disorders. So 4 disorders are included in this chapter. The other specified mental disorder due to another medical condition, unspecified mental disorder due to another medical condition, other specified mental disorder, and lastly, unspecified mental disorder. So this residual category applies to presentations in which symptoms characteristic of a mental disorder that cause clinically significant distress or impairment in social, occupational, or other areas of functioning predominate but do not meet the full criteria for any other mental disorder in DSM-5. So other specified mental disorder due to another medical condition in this category applies to presentations in which symptoms characteristic of a mental disorder due to another medical condition that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any specific mental disorder attributable to another medical condition. The other specified mental disorder due to another medical condition category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any specific mental disorder attributable to another medical condition. And this is done by, first, recording the name of the disorder with the specific etiological medical condition inserted in place of another medical condition, followed by the specific symptomatic manifestation that does not meet the criteria for any specific mental disorder due to another medical condition. Furthermore, the diagnostic code for the specific medical condition must be listed immediately before the code for the other specified mental disorder due to another medical condition. Next, we have unspecified mental disorder due to another medical condition. This category applies to presentations in which symptoms characteristic of a mental disorder due to another medical condition that cause clinically significant distress or impairment in social, occupational, and other important areas of functioning predominate but do not meet the full criteria for any specific mental disorder due to another medical condition. The unspecified mental disorder due to another medical condition category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for a specific mental disorder due to another medical condition, and includes presentations for which there is insufficient information to make a more specific diagnosis, for example, in emergency room settings. And this is done by recording the name of the disorder with the specific etiological medical condition inserted in place of another medical condition. Furthermore, the diagnostic code for the specific medical condition must be listed immediately before the code for the unspecified mental disorder due to another medical condition. Next is we have the other specified mental disorder. This category applies to presentations in which symptoms characteristic of a mental disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any specific mental disorder. The other specified mental disorder category is used in situations in which the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any specific mental disorder. And this is done by recording other specified mental disorder and followed by the specific reason. Now we are down to the last disorder, which is the unspecified mental disorder. This category applies to presentations in which symptoms characteristic of a mental disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for any mental disorder. This disorder category is used in situations in which the clinician chooses not to specify the reasons that the criteria are not met for a specific mental disorder, and includes presentations for which there is insufficient information to make a more specific diagnosis. And that is the overall coverage of our topic under paraphilic disorders and other mental disorders. Thank you all for listening, and I hope you have learned something from my report. God bless.